Hello, I'm back. And this week we're going to be continuing our journey on learning the different types of reimbursement, particularly as they pertain to CMS. And with that in mind, we're going to be talking about hospital outpatient services and how they're paid. And again, here we go with hospital outpatients. And we talked in the announcement about bundling, packaging. Some of these are new, but a little bit of a new context in terms of some of these terms. And what we have is hospital outpatient systems, or as we call outpatient prospective payment systems. And like the inpatient prospective payment system, it's a way of limiting payments. It's not just solely relying on what the hospital's fee schedule is. And this covers such things as clinics, hospitals with attached emergency department. We always think of emergency department as being part of a medical center, part of a hospital, and it is for licensing purposes, but the vast majority of patients who are seen in the emergency department actually go home. We also have ambulatory surgery units, and these are things that are done for procedures where the patient goes home. And this is a little bit different than the ambulatory surgery centers. And again, these things are updated yearly by CMS, new regs coming out all the time. We hope to capture the majority of the current ones here. There are three different ways that hospitals are reimbursed for outpatient services, and this includes things that we're used to. The fee schedule. You have an ambulance ride from, somewhere to Riverbend Hospital or what have you. There is a fee based on miles or what have you, based on time for physical therapy. If you're using oxygen, there's a bill for that. We also use, kind of similar to inpatient hospital MSDRGs, we use another classification, and this is called APCs, or ambulatory payment classifications. And then finally, we have reasonable cost. So this is basically looking out to see what is it going to cost for corneal tissue, a Hep B vaccine, what have you, that's out there, and what's reasonable to pay for it. So three different ways that hospitals are reimbursed for outpatient services. And again, APCs, let's take a closer look at this. So basically, with MSDRGs, we took conditions and kind of grouped them together, MSDRG 271, and then we have things that would drive it to a different DRG if there was a major complication, what have you, right? So in this situation, what we're doing is grouping like procedures that use similar resources together in another payment classification, except instead of on the basis of what the patient's diagnosis is, we're grouping it on procedures. The diagnosis doesn't really play a role per se in the grouping, although obviously we're going to be doing procedures for certain types of diagnoses, right? But what drives it and what determines what APC it goes into is what the procedure itself is. And this is where we get into packaging and bundling. With packaging, we're going to be reimbursing for minor things that are associated with it, right? Bundling is basically kind of moving everything that's a separate procedure into one. And we're going to take a look at this in examples 7.1 and 7.2 in the text. And here's what we're talking about in 7.1. Patients seen in radiology, they have an MRI with contrast. We see a CPT code, and the contrast is reported with a code of Q9953. Under the OPPS packaging, the contrast medium is considered a supportive service and it's included in the MRI. So in other words, the hospital doesn't get paid separately for the contrast. Seven two here we see an issue of the bundling. We have a patient who's seen for continued neck and back pain. The provider orders an MRI. The MRI, each region is an individual component, so it's separated. We have the cervical, thoracic, and lumbar vertebrae. And when these three components are provided during the same encounter, the payment's going to be combined into one APC. Well, we can also have partially packaged systems. So basically, we're encouraging the hospital to provide some efficient care and manage resources with flexibility rather than just saying it's either this or that. So basically, what we're doing is encouraging the hospital to choose the most cost efficient option when a variety of devices, drugs, items, and other supplies are utilized. We're encouraging hospitals to negotiate with manufacturers and suppliers to reduce the purchase price for supplies and items. And then finally, we're going to influence the hospital to have protocols to ensure the necessary services are provided. So we're making efficient use of all the resources. So now we have payment status indicators. So basically, this is a code that's telling us how a service or procedure is paid. We talked earlier about the three ways that services are paid, either a fee schedule, an APC, or reasonable cost. So let's take a look at what that means per our example in 7.1. And you can see that right here. We have under the OPPS packaging, the contrast medium, right? So it falls into this APC. This is how they're being reimbursed. So again, the status indicator is assigned to the HCPCS codes, and this comes out in Addendum B of the OPPS final rule. This is updated quarterly. And these HCPCS codes are reported per the encounter, so there's multiple status indicators for each encounter. And CMS uses logic with the outpatient code editor and pricer to determine what's paid appropriately. So each HCPCS code can only be assigned to one APC, as we saw in figure 7.1. We can only have one HCPCS code. And basically, this grouping is looking at the relative weight, which is a reflection of how resource intensive the HCPCS code service is. And the national unadjusted payment amount is the total reimbursement amount. So another term we hear are pass-throughs on drugs and biologicals, non-pass-throughs, significant procedures. So all these things are different items, line items, that get added on. So we can see an example of this in 7.3 that'll spell out some of the things that we see on the other side of this, on the left-hand side of the slide. And again, you can see the status indicator over here. If it's A, it's going to be fee schedule. If it's B, it's not reimbursed. G is APC, and then the pass-through, with which we'll get into in a little bit, and so on. So here's the example that we're looking at. Patient is seen for wound care after she fell and lacerated her scalp. During the wound care visit, the physician treated her for a split wound and gave the patient an injection of lidocaine to numb the area prior to the sutures. The injection of the lidocaine and the supplies required to perform the closure are packaged. So in other words, we can't carve those out and charge extra for the lidocaine. So you see the CPT code here. You see the lidocaine injection, right? So only the services with the status indicator of T, in other words, the closure, is payable separately. And we have payment status indicator categories, the comprehensive APC, the CAPC. So if it's all inclusive, we have our primary procedure. Most other procedures, services are packaged into it. The comprehensive, this is like the one that trumps all of them, the king of the status indicators, if you will, the J1. And this kind of covers everything. Almost all other services are packaged, including other J1 and J2 procedures. And then finally, we have J2. Services are paid through a comprehensive APC, and they're packaged if billed on the same claim as a J1. And that's all I have for you. We'll see you online. Bye now.